Greetings from Department of Pharmacology, Sree Balaji Medical College and Hospital. So I am Dr. Saujanya, Assistant Professor, Department of Pharmacology. So last class we have already learned about various routes of drug administration. This class we will be learning about pharmacokinetics, the component of pharmacokinetics, absorption, distribution, metabolism and elimination. But today we will learn in detail about absorption. So at the end of the class, the students should be able to answer what is absorption, various sites of absorption, and also you have to learn about various factors influencing absorption, what is bioavailability and what is bioequivalence, and also how we calculate bioavailability and bioequivalence so that we can compare different product of pharmaceutical products and also different various formulation, how the absorption can be made better, and also various factors that will influence the absorption that can increases the absorption or various factors that can delay the absorption of drugs. So today we will be learning about absorption. So we know that terminology pharmacokinetics. Pharmacokinetics is what the body does to the drug. So its components are absorption, distribution, metabolism and elimination. So the first step of absorption. So absorption is the movement of the drug into the bloodstream from its sites of administration. It is the site from where the drug is absorbed. So we will be learning about various sites of drug absorption. So the main and major part of absorption of a drug, oral drug, is from the gastrointestinal tract. So it is mainly by passive diffusion. So smaller molecular size drugs can diffuse through the pores in the cell membrane. So it also based on the pH that forms a major role for the absorption of various drugs. So from mouth, the saliva pH is 7.4. So lipid soluble non-ionized basic drug or neutral drugs are absorbed because the non-ionized basic drug will remain unionized in the pH of 7.4. So it will be get easily absorbed from the mouth. In sublingual absorption, which will reach the systemic circulation bypassing first pass metabolism. So it will be directly absorbed into the sublingual veins. So the examples of sublingual route of absorption drugs are isosorbate dinitrate. So from stomach, the pH is acidic. So the non-ionized lipid soluble acidic or neutral drugs are absorbed. So here also the acidic medium, the acidic drugs will remain unionized and it will be easily absorbed in the stomach. So drugs like aspirin, which will also pass through hepatic portal system. So from the GIT, it is absorbed into the hepatic portal system and it will undergo first pass metabolism in liver. So from intestine, the absorption, the major site of action for most of the drugs is the intestine. So the pH of intestine is alkaline. So the lipid soluble unionized basic drug remain unionized in that medium, or the neutral drugs will be absorbed from the intestine. Examples are morphine. From liver, some drugs are secreted through bile and so from the intestine, what happens? The drug is absorbed and it will enter the hepatic circulation. From hepatic circulation, it will be secreted through bile in the intestine, and again it will get reabsorbed. So this is called as enterohepatic circulation. So moving to large intestine or colon, the pH of the colon or large intestine is alkaline. So unionized basic or neutral drugs are absorbed from large intestine or colon. So another thing here is the external hemorrhoidal vein will come into play. It will take in the drugs into systemic circulation. So there is minimal first pass effect when you give drugs through these routes, because the drugs will be directly absorbed into the external hemorrhoidal veins. So the route of absorption, the absorption is more with sublingual route, then the rectal route, then comes the oral route, because of the first pass metabolism that come into role in oral absorption. So the other routes like parenteral sites. So when you give, you have learned about the routes of administration. So when you give a drug through parenteral site, that is intravenous route, the drug will directly go into the bloodstream. So the drug 100% will reach your circulation and will be available for usage. Then intramuscular and subcutaneous route, by passive diffusion from the intramuscular or subcutaneous tissue, by passive diffusion the drug will enter the plasma or lymphatic system. So the absorption is of IM, intramuscular route, is more rapid when compared to absorption through subcutaneous route. So in this route, the absorption is reduced when there is a shock, that is, when there is a circulatory failure or when the patient is in shock, the absorption of drug through IM and subcutaneous route is reduced. So the absorption more with intravenous route, then comes the intramuscular route, then the subcutaneous route. Then the other route of drug absorption is your lungs. So lipid soluble drugs in vaporized form, that is general anesthetic agents, or aqueous solution spray like salbutamol, the drugs used for bronchial asthma, these come as vaporized form. This gets absorbed by passive diffusion from pulmonary epithelium, trachea and lungs. So the absorption through this route is also rapid because of the large surface area and also due to high vascularity. So that there is no first pass metabolism through this route. The other routes of absorption are topical, that is your cutaneous tissue or the skin. The dermis is permeable to lipid soluble drugs. Transdermal patches are available for absorption of drugs like nitroglycerin, scopolamine and clonidine. Then you have other topical agents like cream, ointment, where absorption happens through your dermis. Then mucous membrane, oxytocin and vasopressin are available as nasal spray, that is absorbed from the nasal mucous membrane. And also eye drops or eye ointment is getting absorbed through the cornea. So now we are moving to methods for delaying absorption. So how we can delay some absorption? So that is by the dosage form. The formulation, modifying the formulation of a drug, the drugs can be retard absorption. So retard tablets, spansules, depot injection, subcutaneous implants, these are for different formulation that will reduce or delay the absorption. So the slow and sustained, it will give an slow and sustained absorption. When you change the formulation of a drug, like when a tablet is converted to a retard type of tablet or spansules or depot injections, there will be a slow and sustained absorption. So changing the physical characteristics of a drug. So when insulin is combined with zinc as suspension, we can modify that into a prolonged absorption insulin. So procaine penicillin aqueous suspension, the duration of action of the drug is prolonged. Then by adding a vasoconstrictor drug. So while administrating adrenaline with xylocaine, so adrenaline is a vasopotent vasoconstrictor. Xylocaine is a local anesthetic. When you add on these two drugs, what happens? The action of local anesthetics, that is xylocaine, is prolonged. So methods to facilitate absorption. So how to increase the absorption? By applying a tourniquet. In case of applying a local anesthetic for a procedure in hand or in limbs, when if you apply a tourniquet, the IV injection of local anesthetic will remain in that area rather than getting absorbed into systemic circulation. So the drug effect can be increased due by this procedure. And adding hyaluronidase increases the rate of diffusion of a drug. Then also by applying hot fomentation or doing a massage increases the local blood flow, thereby the absorption of drug can be improved. Then moving to two terminology that we use in absorption or bioavailability and bioequivalence. So what is bioavailability? Bioavailability is the rate and extent to which the active concentration of the drug is available at the desired site of action. So the bioavailability came into existence in the year of 1968 in Australia when their phenytoin toxicity in epileptic patients were reported by changing the excipients. So the excipient was changed, that is the substitution of lactose was done in spite of calcium sulfate as inert excipient, which increased the plasma concentration to 30 microgram per ml in epileptic patient, and that resulted in toxicity. That is how this bioavailability came. So bioequivalence. So what is bioequivalent preparations? What is the term used as bioequivalence? So bioequivalence is a term when two or more similar dosage forms of the same drug, when we are comparing two or more similar dosage forms of the same drug that reach the blood circulation at the same relative rate and extent. So when you say something as bioequivalent preparation, that is the two or more similar dosage forms of the same drug that will reach the blood circulation at the same relative rate and extent. So the differences in bioavailability seen with oral dosage forms. So differences in bioavailability will assume greater significance when drug which follows zero order or mixed order kinetics. That is, when phenytoin, warfarin, oral anticoagulant, digoxin and aspirin, these drugs follow zero order or mixed order kinetics that you will learn in elimination. But these drugs also have a narrow margin of safety, that is narrow therapeutic index drugs like antiarrhythmic, antidiabetics and theophylline. In such cases, the change in brand or formulation, like when a patient is taking a certain drug of one company, switch over to same drug of different company, there may an intoxication may occur or therapeutic failure can occur. If the narrow margin of safety means these drugs have narrow therapeutic index. When they change the brand formulation, they can go for a therapeutic failure or drug intoxication. So we have types of bioequivalence, that is chemical equivalence, pharmaceutical equivalence, clinical equivalence and therapeutic equivalence. So in chemical equivalence, if two or more dosage forms of the same drug contain the same labeled quantities of the drug, we say that it is chemically equivalent drug. Then pharmaceutical equivalence is along with the same quantity of the drug, when the drug is having same excipient, we say this is pharmaceutically equivalence drug. Clinical equivalence is when if one structurally different drug provide the same pharmacological response qualitatively of the other, then we say this is clinically equivalence. For example, phenothiazine group of antipsychotic drug, trifluperazine, and butorphanol group of haloperidol antipsychotic drugs are used for schizophrenia. Then therapeutic equivalence is if two brand products of same drug provide same pharmacological effect, then it is said to be therapeutic equivalence. So we have a calculation that is done for bioavailability. So the characteristics of plasma concentration time curve. So we have C max, that is peak plasma concentration, T max, which is time to attain peak plasma concentration, that indicate the rate of absorption. Then we have area under the curve of plasma concentration versus time curve, which reflects extent of absorption. The area under the curve is expressed in milligram hour per ml. It is calculated by planimeter, cut and weight method, and using a trapezoidal rule. So, measurement of bioavailability can be done to compare the absorption pattern of two formulation or brand products of the same drug using the formula. So, the bioavailability is the area under the curve of oral by area under curve of IV into 100. So this is the plasma concentration time graph. We can see the two formulation A and formulation B, how it is absorbed and how through the process of time, how it declines, the plasma concentration, how it declines. So we learned about C max is the concentration maximum, and area under the curve is below the curve, that is used for calculation. Then T max is the time where the plasma concentration reaches its peak, that is T max. So we have minimum toxic concentration, that is beyond which when the drug attained in the plasma concentration will be a toxic. Then we have minimum effective concentration, below which when the drug level falls below that, the effect will be declined. So now moving to factors influencing absorption. So we have pharmaceutical factors, pharmacological factors. So the pharmaceutical factors are the absorption depends on disintegration time and dissolution time rate. So the particle size. So drug dissolves more rapidly when its surface area is increased by decreasing its particle size. So microfined aspirin, digoxin, griseofulvin, these, when the particle size is reduced, the absorption is more. Then you have salt forms. So salts of weakly acidic drugs are highly water soluble because they show faster dissolution. So example is phenytoin sodium. So when a drug is absorbed from the oral absorption, that is oral administration of drug in any dosage form like tablet, capsule, powder, solution or suspension, it will go into a step called disintegration. So tablet or capsule will follow disintegration to fine particles. This fine particle will undergo dissolution in water, that is drug, that will form drugs in solution. From that only it will be absorbed in the GAT. So tablet or capsule will follow all these steps, and powders and suspension will follow dissolution. Solution, if it is given in, if any form of drug given in solution, it will be absorbed through GAT directly. Then you have a crystal form. So amorphous form has faster dissolution rate than crystal form, that is chloramphenicol palmitate. Then water of hydration, anhydrous forms of caffeine, theophylline, ampicillin have faster dissolution rate and better bioavailability. Then you have nature of excipient and adjuvant. So pharmacologically inert substances like starch, lactose, calcium sulfate, gum, polysorbate 80 is added as a filling or binding agents to obtain proper granular size. So it also affect the influence the rate of absorption. So lactose and polysorbate 80 are wetting agents which enhances solvent penetration, minimize particle aggregation. Any change in brand formulation could lead to therapeutic failure or intoxication for drugs having zero order elimination and low therapeutic index. Then degree of ionization, non-ionized lipid soluble drugs are better absorbed. So moving to pharmacological factors, about gastric emptying and GI motility. So the factors that accelerate gastric emptying will increases the bioavailability. So it is promoted by fasting, anxiety, lying on the right side, hyperthyroidism, metoclopramide, which is a gastrokinetic drug, which will promote the absorption of any drug. So the absorption of drug is retarded by fatty diet, depression, pyloric stenosis, hypothyroidism, and lying on the left side, and drugs like atropine and propanthelin that will reduce the gastric motility, thereby retard the absorption of drugs. Then you have gastrointestinal diseases like celiac disease. The absorption of amoxicillin is reduced and cefalexin is increased in celiac disease. Then Crohn's disease, there is a disproportionate absorption of individual compounds of cotrimoxazole. That is, cotrimoxazole is a combination of trimethoprim and sulfamethoxazole. But in Crohn's disease, the absorption of trimethoprim is reduced and sulfamethoxazole is increased. So in gastroenteritis, there is reduced absorption of orally given drugs. Then food and other substances. So food plays a major role in influencing the absorption of drug. So absorption is favored by an empty stomach. And absorption rate of rifampicin is reduced after meals. Tetracycline, the absorption is reduced when it is given along with milk. And vitamin C will increases the absorption of iron. Then griseofulvin absorption is increased with fatty diet. Then first pass effect. So that is the degradation occurs before the drug enters the systemic circulation. So few drugs, most drugs that will go into circulation, that will go into hepatoportal vein and enter the liver, it will go into first pass metabolism. Then again it will be secreted through bile in the intestine. Again it will get absorbed. So before reaching the systemic circulation, these drugs have gone through enterohepatic circulation. Some drugs have gone through enterohepatic circulation and reabsorbed. Some drugs have degraded by the liver in the first initial absorption itself. So the amount of drugs absorbed into systemic circulation is less. So some drugs which follow the enterohepatic circulation will have a prolonged duration of action. So the examples are levodopa, morphine, NTG, propranolol, isosorbate dinitrate, which will go follow first pass effect. So other factors like drug-drug interaction, that is liquid paraffin will reduces the bioavailability of vitamin A, D, E and K, and antacids can reduce the bioavailability of tetracyclines. Probenecide blocks penicillin excretion. So probenecide and penicillin will compete for same transporter in the, and also it will blocks the, they will compete for the same transport. So barbiturates, which reduces the bioavailability of many drugs by enzyme induction. Then you have pharmacogenetic factors like genetic plays a major role in the absorption of drug. Like some drugs like slow acetylators like isoniazid, which induces the hepatotoxicity due to increase in absorption and metabolism. Atypical pseudocholinesterase like succinylcholine, it can cause apnea due to the atypical pseudocholinesterase enzyme. So today we have learned about the pharmacokinetics absorption. So that is the first and foremost step, how the drug will go inside our body and into systemic circulation. So we have learned about various sites of absorption, that is from GIT, we have from how it is modified from the oral routes and also different GI tract, and also from the topical, then lungs, how it is absorbed into systemic absorption. And then we have learned about bioavailability of drug, that is how much is absorbed after all these steps, how much is into the circulation, how much it is available in the plasma for the usage in the body, and also about bioequivalence, that is the comparison of various formulation of drug or the same formulation of the different brand pharmaceutical drugs, how we compare the effectiveness of the two drugs. And also later we have learned about factors that will modify the absorption, how each portion, that is how it is modified in the GI tracts, how it is modified in the absorption tract, that we have learned. Thank you.